Right, so I've been asked to talk about a clinical trial called CALYX, which is a randomized controlled trial looking at leriglitazone in cerebral adrenoleukodystrophy in adults. And it is currently the only trial that I'm aware of that's available in the UK for adults with ALD or indeed AMN at the moment. So, does that work? No. We'll have a few slides about cerebral ALD and its current treatment. You've heard a lot about that today. And then I've got some slides which are mostly kindly from Aaron Meestry from Minorix. So they're his slides, but you're going to get my spin on them rather than his spin on them this time. Sorry, Aaron. I think we'll agree on most of it. Right. So cerebral adrenoleukodystrophy is one of the subtypes of XALD. Most common onset in children, childhood CALD and adolescents, but is occasionally seen in adults de novo. So there are a few adults who present for the first time with cerebral adrenoleukodystrophy. I'd have to say that by the time they get to clinical presentation, they've normally got quite advanced disease. And it's also something that we occasionally see or progressively see over time in men with AMN. And the estimates at the moment that 20% of men with AMN who escaped having ALD at these earlier times in life will develop cerebral disease over a period of 10 years or time, although it may behave quite differently from this cerebral disease we see in children. So it is something that there's an ongoing risk of, but the risk gets less as you get older. And James has just gone over this. There is currently a treatment for cerebral ALD, and that's bone marrow transplantation. And over on this side, we're looking at overall survival of patients and survival of major functional disability free, so patients in a good state over time with cerebral ALD, which isn't good if you're untreated, but then if you treat patients, you start to see much better survival and much better symptom-free survival, but it's much better, as James said, if you treat patients earlier rather than later. So if you treat them late, unfortunately the outcomes are not good. If you treat them early, the outcomes are much better, which is why we scan routinely so that we can offer HSCT early. Most of that data, if not all of that data, was generated in children. What do we know about adults? And this is data from Wolfgang Köhler's group that was published a number of years ago now, looking at, this is about now adult patients with CLB, looking at all patients' survival, and looking at patients with no or mild symptoms in their survival, they do better. And again, with bone marrow transplantation, again, we won't go over each of the graphs, but the message is you need to do it early. You can actually improve survival and improve symptom-free survival. So it is also an approach you can use in men, and we are now able to offer that in the UK as well, under the criteria that we catch it early enough, so that the MRI at the time we catch it isn't too bad, and that if they have also adrenomyelin neuropathy, there isn't disability that's so severe that it's going to make the bone marrow transplant much more dangerous, and the problems with illness and death associated with the bone marrow transplant become more than they are with the disease. And that's because there are complications of HSCT. So this is the same group of adult patients who were transplanted. And if you look over here for the outcomes, so HSCT is not without its problems. So 1, 2, 3, 4 of these patients died actually from complications of one from complications of the disease, others from complications of the bone marrow transplant. So it's not something to be undertaken lightly. And if we had another option that was safer and effective, that would definitely probably be preferable to having to put people through a hematopoietic stem cell transplant, bone marrow transplant, particularly adults who have other symptoms as well with AMN. So there is a need, there's an unmet need for a better treatment. Okay, so that's the ALD and the HSCT, which we've done before. This is the leriglitazone bit. So we've talked about leriglitazone at these meetings before, over a number of years now. And leriglitazone was originally went into clinical trials to see whether it had an effect on the progression of adrenomyelin neuropathy. So Minorix did a big clinical trial called Advanced in men with adrenomyelin neuropathy, again placebo-controlled. So some men got the drug and some men got placebo for 2 years actually, and then at the end of that 2 years everyone started getting the drug. aimed at looking whether it could slow down the progression of that disease. Did the patients who were treated with leriglitazone have a slower progression as measured by ability to walk, as measured by balance, than the patients who had placebo? So, and that's been published back in 2023 now in Lancet Neurology. And unfortunately, it wasn't possible to show a statistically detectable alteration in the progression of the adrenomyeloneuropathy. So there wasn't data to support it having an effect on adrenomyeloneuropathy. But they did look at a lot of other things as well. And one of the things they looked at was MRI scans. So patients actually had an MRI scan at baseline, mainly for the reason that they didn't want to include patients who had cerebral adrenoleukodystrophy in this trial. So they were looking to make sure that if patients had gadolinium-enhancing lesions, they weren't going to be included. So everyone had an MRI at baseline, and then they had further MRIs as they went on, just to make sure that no one was developing it. And what they saw was actually quite unexpected, but if you looked at the change in Lois score, and you looked at the patients who were treated with leriglitazone, it was a 2-to-1 randomization, so twice as many patients got leriglitazone as got dummy. And if you looked at those who actually looked at those MRIs and worked out between baseline, I think these were done at 2 years, what changes there were in the MRI, there was much less progression in white matter disease in the MRI of patients who were treated than there was in the MRI of patients who were on the placebo. And that was a statistically significant difference. And then if you went on and actually looked at progression of cerebral, so those who had cerebral lesions, none of them had gadolinium enhancement at baseline, but some had cerebral lesions. Had they got worse? In 3 of the patients on leriglitazone, they got worse, but in 8 of the patients who had changes at baseline on the placebo, they got worse. And if you actually looked at patients developing a cerebral adrenoleukodystrophy during the study, there were none in the group treated with leriglitazone, and actually 15% of the placebo group developed some signs of that. So unexpectedly, it looked like leriglitazone, although unfortunately we weren't able to detect an effect on AMN, might have a significant effect on prevention of progression of cerebral lesions in the brains of men with AMN, and perhaps in prevention of cerebral ALD in men with AMN as well. So what this shows you is that it may be preventing disease. It doesn't tell you anything about whether it can treat cerebral ALD, because we'd excluded men with active cerebral ALD from the study to start off with. And this is just looking at the same data and one of Minerix's slides. So these were patients that, of the patients in the trial, 71% didn't have any visible lesions on MRI at baseline, but there were 27% who did have abnormal MRIs at baseline, but none of those had enhancement with gadolinium because they would have been excluded from the trial. So in those patients, they were looking at how many of those patients who had lesions at baseline, they actually progressed. And that's where they saw, this is showing you the same data really, that on placebo, 6 of the 39 patients progressed, but none of them progressed to CALD, we're talking about here, not just the lesions progressing, but getting gadolinium enhancement. So 6 actually developed gadolinium enhancement, and none of these patients do. So we're perhaps preventing the development of cerebral ALD. So that was the advanced study, which was a study, as we said, that was designed to look at men with AMN, not at men with ALD, but had a positive result in that it suggested that there might be an effect on ALD, although the study wasn't designed to do that. So it wasn't one of the primary outcome measures, and it wasn't statistically powered to do that. So it was difficult to make that conclusion, and certainly the regulators weren't willing to accept that as a conclusion from that study. So since then, they've gone on to do other studies looking at this question of what's the role of leriglitazone in cerebral disease rather than adrenomyeloneuropathy. And there are 2 studies. One is Nexus, which is a study that's been done in pediatric patients, so boys between 12 years who have cerebral ALD, different population of patient this time. These patients had to have cerebral ALD, so they had to have gadolinium enhancement at baseline. This is open label, so there's no placebo control in here. All the patients are offered leriglitazone, and then they've been analyzed at 6 months, and then 96 weeks, almost 2 years, which is ongoing. The data from that, or at least the initial data, has been presented, and we'll come to that in a minute. And then they've also had, so that was a clinical trial. There's also been a compassionate use program. So a compassionate use program of a developmental drug is where clinicians can go to the company and say, I've got a patient who's got this condition. It might benefit from your drug. Would you be willing to let us have it to treat this patient on a compassionate basis, not as part of a clinical trial, but to see whether it has any effect? But if you have enough of those compassionate patients, you can actually pull that data together and see whether you're having an effect or not. And so this has been made available at different times in a number of different countries to boys and adults with cerebral ALD who weren't able, basically, to have bone marrow transplantation. And they've treated 30 patients who've had baseline MRIs, and then, so 30 of them have had further MRIs done, treated for more than 2 years altogether. And there have been some assessments of the lesion growth, and there's some data on that available from the French cohort now. So this is the Nexus study, trying to see whether leriglitazone can delay the progression of established CALD in boys. So these are patients so this is looking above natural history. Let's go put the other slide up for you. So the natural history, if you've got gadolinium and brain enhancements to actually progressing, is that only 10% of those patients will stop progressing at 2 years. So what we know from history is that about 10% of boys who develop cerebral ALD will actually burn out and stop progressing, and they'll have a period at least of stability. So when they treat a patient, they look at the patients who were treated with leriglitazone, and they've looked at 6 months on 11 patients. So those 30 patients, 11 of them, they've got data at 6 months. None of them had clinically progressed. So they've either stopped going or they're clinically stable and there's no significant growth. So that's 0%. So it looks like there's a signal from the data there that actually leriglitazone in patients who've already got cerebral ALD may also be able to stop it from progressing. So Advance suggested you may be able to prevent it. This suggests that you may also be able to use leriglitazone to treat patients with cerebral ALD, perhaps. And then this is data that's been published more recently by Fanny Marchel's group in Paris, looking at patients, adult patients this time, with CALD who they've treated in the compassionate use program. There's a wide age range. They all have progressive CALD and were, for whatever reason, not able to have bone marrow transplants. Some weren't suitable, some were waiting for donors, and were having leriglitazone in the beaten part. And 10 of 13 of those patients have been clinically and radiologically stable for at least a year. So there's been no change in their disease over that first year. 3 of them weren't. Among those 10 stable patients, 4 actually improved clinically, so the symptoms they had got better. 2 patients didn't want the treatment. 1 patient died of COVID. And patients who had gadolinium-enhancing lesions at the internal capsule, which is one of the earliest signs of cerebral ALD, some of them showed gadolinium enhancement. And of the patients who've been listed for HSCT in that particular cohort, none of them are actually requiring HSCT anymore. So that wasn't a clinical trial. It's not designed to answer a question statistically, but looking at experience in a number of patients who didn't fulfill any particular criteria other than they had CALD, again, it's suggesting that there may be an effect on actually being able to help with progression of the disease. But we need to do a clinical trial to actually try and answer that question once and for all, and that's what CALYX is. So the regulatory authorities want a randomized control trial. And control means some of the patients are going to get placebo, not your drug. So CALYX is what we call a phase 3 study, so it's actually looking for a clinical outcome in adult patients with cerebral ALD. It's randomized and placebo-controlled. So to get into this study, you'll need to be an adult, you need to be more than 18 years old, and you need to have active cerebral ALD and not be either suitable or willing to have a bone marrow transplant. You need to have gadolinium, this is the wrong way around here, so you need to have gadolinium enhancement lesions, but you also need to have a LESS score that is less than 12, not more than 12. So actually your disease can't be too advanced, and we'll come back to that. But this isn't going to be available for most patients with disease that's too advanced for hematopoietic stem cell transplantation. That's because we think those patients are, if they're too advanced for HSCT, it's quite likely that they're going to go on progressing if they're on leriglitazone as well. They want 40 patients, and they're looking in the US and now opening some sites in Europe to look at that as well. And the primary endpoint, so what they're really looking for, is whether we can prolong survival. So whether these patients survive longer than patients treated with placebo, And there's also another one with getting to a point of what we really regard as the most severe part of cerebral ALD, which is when you're in bed and you're needing support with your ventilation here. We don't see this very often, so death is really going to be the thing. But they're also looking at the LESS scores as well to see whether it stops progressing. So here's the trial design. There's an opportunity for patients with AMN who are asymptomatic to be screened. So to get a screening MRI, in this country we'd hope that we'd be starting to screen everybody once a year anyway, but if you had an MRI, you can come in and have an MRI. If that then shows evidence of gadolinium enhancement, you can enter the trial. And you will either, and this is a one-to-one randomization this time, so you'll either go into leriglitazone or you go into placebo, and that's an 18-month initially period. So for 18 months, at least, you will either be getting leriglitazone or placebo. Once all of these 40 patients are in, and the last patient in has been on the drug for 18 months, so that means the first patient in will be on the drug for a lot longer than that, there'll be an analysis of the data, and that analysis is going to look at basically whether it's prolonging survival or not. If it's if it does, then everybody gets to go over to leriglitazone. If it isn't statistically significant yet, we'll go on for another 9 months, and then another 9 months, until we actually find out whether we have a definite effect. So in the first instance, it's going to be placebo-controlled for at least 18 months, and for some of the patients who go in earlier, for longer than that. And the inclusion criteria, so this is the important thing about what you need to be in order to get into this trial. So as we've said, you have to be male, but you won't get cerebral ALD unless you are. You have to be an adult. It has to be progressive, so you have to have a gadolinium-enhancing brain lesion on your MRI. And there has to be a good reason why you can't have a stem cell transplant, because we know that works, whereas this is a clinical trial of something we don't know that works. So either if there are reasons why you're not suitable, or for whatever reason you yourself don't want to have a bone marrow transplant and are willing to go into a placebo-controlled trial where you might get nothing instead. And then there's this your LOI score. You have to have gadolinium enhancement, so that's your LESS score of more than 5, but it can't be too severe. It has to be less than 12. And there's also stuff about not having too much disability. So if you're already wheelchair bound or needing intermittent self-catheterization, then you'll probably be excluded. Exclusion criteria. So this is, we've said what you have to be to get into the trial. This is a whole list of things that will make you out of the trial. So if you've previously had bone marrow transplantation or treatment with any of the gene therapies, you're not going to be eligible. If you've got diabetes, you're not eligible, and that's because of the effects of leriglitazone on diabetes. And there's some other exclusion criteria that are much less likely to be a problem. Endpoints, so as we said, the primary thing they're looking at is survival, so time to death. And this is a very good endpoint for clinical trials. I mean, this, if lots of drugs get approved for cancer, this is the survival endpoint they use in cancer trials. So regulators are very used to dealing with this. When we deal with something like AMN and we're looking at disease progression and we're saying, oh, they might be able to walk a bit further or their balance will be a bit better, that's much harder to demonstrate than people surviving longer. So that's a good primary endpoint from the point of view of regulators, although unfortunately it's not a great primary endpoint from the point of view of patients, perhaps. And they're also going to look at the LESS score, so whether we can actually see whether the brain lesions are not progressing as fast. And then there's a number of functional tests looking at your symptoms, basically. This is motor function, major functional disability. Is it actually helping people not get worse or even get better from the point of view of their symptoms? The sites are active already in the US, so there are patients being recruited in the US and in Brazil and South America, and there are sites going to be opened up in Europe, so we're ethical permission has gone in the UK. The committee have looked at it the first time. I don't think we're going to have major problems, so hopefully we'll get ethical permission. Then there's a lot of negotiation that goes on, but we would hope to be up and running towards the end of the year, and there'll be sites in Germany, France, and Spain as well, with the aim of recruiting 40 patients as quickly as possible, I think, from Minarix's point of view, so they can get the data as quickly as possible, because it's going to be at least 18 months from the last patient going in. So this is a trial that's aimed to look at not what actually was suggested by Advance, that leriglitazone might prevent the occurrence of cerebral ALD. We're actually looking at whether it can alter the history of the disease in patients who've already got it. So there's still an outstanding question about whether we can actually stop it happening at all by treating people with leriglitazone. We don't know that yet, and this isn't going to answer that question. But it may tell us whether this is going to be an alternative treatment to hematopoietic stem cell transplant in due course in this very selected group of patients. I'll stop there.